Hello, everyone, and welcome to today's webinar, Best Practices to Successfully Navigate the Future of Healthcare. My name is Alex Goulding. I'm the Public Policy Manager here at iHealth and will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using your computer speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed. You will have the opportunity to submit questions during today's presentation by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and, time permitting, address them during the Q&A session at the end of today's presentation. Also, please note that Justin's slides will be shared in a follow-up email after this presentation in case you want to review again or share with any peers. I would now like to introduce Justin Barnes. Justin is a corporate, board, and public policy advisor. In addition, he's Chairman Emeritus of the HIMSS EHR Association, co-chairman of the Accountable Care Community of Practice, and partner at iHealth, where he assists organizations with industry strategy and leadership. Justin is also the host of the weekly syndicated radio show, This Just In, on Healthcare Radio and Business Radio X. Justin has formally addressed or testified before Congress, as well as the last two presidential administrations, on more than 20 occasions. He has appeared in more than 1,200 journals, magazines, and broadcast outlets. With that, let me turn today's presentation over to you, Justin.
Thank you very much, Alex, and I truly appreciate everybody taking the time to join us today. I know you're taking an hour out of your day, and so we appreciate you taking the time. And we've chocked this full of a lot of great content, and I'm going to try to. I know I went through the attendee list, and we have a couple hundred people here, and many familiar names. So it's great to have a lot of you back. I've been doing this for about 12 years now, and a lot of you have been with me the entire time. So it's great to see so many familiar names and also new names who hopefully become familiar here. We're going to do these webinars probably every 3 to 4 weeks. I know my team shudders when they hear that, but there's a lot of content here, a lot of good information, a lot of strategic information to help you navigate the future of healthcare successfully. And no matter if you're a practice or a hospital or an FQHC or rural health clinic or whatever you are, there's a lot of strategy in here for you to really thrive. People are just trying to survive out there. Well, I certainly want you to thrive. That's my goal. So again, you're taking the hour today. As Alex said, we'll be sharing all these slides with you within the next 24 to 48 hours. I'm going to try to leave some good time for open Q&A. But again, and for everybody that's been on my presentations, I do cover a lot of ground. I'm initially from Boston, so I tend to talk fast, and I'll apologize in advance. And I'll try to slow it down a little bit, but I have a pretty quick cadence. But again, we'll share this recording with you. We'll share the slides with you. We are going to cover a lot of content. I'm probably going to go through a lot of the content quickly, but again, that's why we share all the slides with you. We share the recording again. We also try to have a robust Q&A session. And again, we'll have these on a very regular basis. You can invite your peers, you can invite your colleagues, and anybody. We always offer them at no cost, and at a pretty, like I said, good cadence. At least once a month, we'll be doing these. So starting off with a changing landscape in healthcare, and I know everybody sees this around you, and specifically, we mainly have hospitals. I think about 75% hospitals on the line. 75% physician practices on the line today, about 25% hospitals on the line today. But all of you are undergoing additional services and strategies so you can successfully navigate the future of healthcare. So that's terrific. And also, I want to congratulate everybody because you've taken the time today to really hear what's happening in healthcare, to spend the next hour with me and understand, what you can do to be successful. And I truly believe, and you'll hear at the end, that anybody and everybody who intentionally engages all these evolving and new payment models and new care delivery models can make more money in the future than they're making today. It's just going to be a deliberate act. Look for the right partner, and you can do much better and have access to more capital and more income for your revenue, for yourself, for your practice than ever before, because it's actually not that difficult. So I'm going to walk through a lot of those components right now. But we're seeing practices and hospitals expand services, certainly expand participation in programs, their partnerships, and consumer access to care. I'm going to touch on all of these throughout the presentation today. And also on the exploration and management of risk-based contracts. It's something that was near and dear to my heart. It's what we walk into practices and hospitals together. Our model here at iHealth is we go 100% at risk to navigate care providers to the future of healthcare. And we're to cover those components of what that really means, and also how you can, size up your practice and or your hospital for that. But obviously, attacking and looking at risk-based contracts is a critical and a key component. Only about 12 or 14% of institutions and organizations across, certainly on the practice side, have engaged that. More so, I think like up to 35 to 40% of hospitals have done that across the industry. Could be a little bit higher on the hospital side, depending upon what region you're in. But that's what kind of, I want to begin to work with you on and cover that base here. But then also specifically, and because near and dear to my heart, is on the physician practice side, allowing physician practices to stay independent. And I've actually seen now a lot of this. Obviously, we all know about the hospital trend of buying up a lot of the practices in communities. And now I call it the pendulum effect. I'm watching now a lot of care providers leave hospitals and health systems and go back out on their own for various reasons. Sometimes they do it strategically because the red tape within the hospital maybe didn't match their entrepreneurial spirit, or they want to practice medicine their way, or the hospital is measuring a lot of results and a lot of outcomes, and they don't keep every single physician and care provider in that type of a setting. So by you taking the time to spend the next 40 or 50 minutes with me, you're going to hear a lot about that, how you can address that, what you can do at the practice level, what you can do at the hospital level to engage every component here. So moving along, and I try to talk in general terms. I do focus a little bit more on the practice side, just so that's where I come from. Actually, I originally come from the hospital side, then went to the practice side for about 15 years, and now on both sides of the fence. My terms tend to fly a little more on the practice side of the house. But it's very important, more than important than ever before, to really focus on optimization, efficiencies within your organization, and certainly economies of scale. How can you do more with maybe a little bit less, or with your current infrastructure, but how can you have more pull-through? And again, I'm going to direct a lot of this as we go through. But you got to look across your organization and your community, your new revenue sources, and higher profitability of current services. And that's critical. So one thing near and dear to my heart, and what we do here at iHealth and why we founded iHealth, was because we optimize the revenue cycle. We think it's very important for you to get paid every nickel that you deserve on your current work. And you would believe when we go out there and look and we do audits for our customers and our prospects, they're leaving tens of thousands, millions of dollars on the table, not being collected. Numerous reasons. I'm going to touch on some of that. But you've got to optimize your revenue cycle. Get paid for all your hard work today, whether you're the care provider, whether you're the CEO, CFO, billing manager, practice manager, whatever your position is, you deserve to get compensated fairly for all your hard work. So that's one that's a piece near and dear to my heart. So I promise you, in my world, I get paid for everything that I do, and I believe every one of our customers should as well. And also to look out there, what new services can you perform? That's something that I love to bring to practice in hospitals. What can you do within your community? What can you do around partnerships to bring new services? What can you bring under your umbrella? I actually worked with a practice in Texas that we were able to go from a standard, I want to say 6-doc primary care group out to 27 providers in a multitude of specialties, then become a mini ACO. Those are the kind of fun strategies that in that practice, in that operation is thriving today. So that's the stuff that we like to bring to practice. There's not to do that. You can just optimize your standard 5-doctor cardiology group, your 8-doctor primary care group today. There's all these opportunities to thrive. And then certainly, bringing on new care delivery opportunities. And that's exactly what we're going to touch on today, as well as new specialty-specific program options. I do spend a lot of time on this webinar around MACRA MIPS, but and hopefully those aren't new terms. I don't like to always throw out acronyms, but hopefully everybody on this call will, I'll dive into that a little bit more and what those acronyms mean. But we also touch on what additional quality reporting programs are available to you in your state. I think it's very important because MACRA and MIPS has to do with Medicare and your volume of Medicare patients. And not everybody has a high volume of Medicare patients. Or even if you do have a high volume of Medicare, that's just one pot of money that we want to help you go after. There's also lots of other pots of money that you can go after, and you can go after today, or starting in 2017, or whenever you want. That's the stuff that we love to bring to practices and hospitals. And whether you're, going for some quality, PCMH, or on the simple side, meaningful use, but certainly PQRS, make sure you're, appropriately calculating for the diabetes modifier, but then also on the district program and Health Home. Those, not home health, but Health Home. That's a Medicaid program in different states across the country. So those are just a few examples of programs that are available today, obviously, and we have MIPS coming starting in 2017 that we want to help you with. But then also looking at conducting business with your, just a basic, never mind all the program stuff that we'll talk about, align processes, services, enable innovation within your organization to ensure that patients can easily access scheduling, appointments, and certainly payment. Those are kind of like a baseline of simple things that everybody can be doing that are very cost efficient, cost effective, and it just makes doing business with your practice and organization much easier. You want to make it so simple for someone to visit you, someone to secure their visit, but then also pay their bill, have their appointment and pay their bill. Make those processes so simple. There is tens of thousands of dollars of revenue, increased revenue from where you are today, just by optimizing those three components. But now, kind of diving into the next level here and getting much deeper, is how to optimize your revenue cycle. And this goes across the board. This doesn't matter if you're a 2-doctor radiology group or a 10-doctor radiology or a 5-doctor OB or a hospital. I mean, we're working with 1-doctor cardiology groups all the way to 800-bed hospitals. Every aspect that I touch on this screen right here is relevant to you, no matter where you fall into that spectrum. So you've got to, if you're near here again, is to review your coding, looking for missing codes, consultations, no notes or wrong providers noted, a lot of undercoding. I don't want to get audited from undercode. You're leaving so much money. I mean, anywhere from, again, $10,000 to $20,000 to $30,000 a month left on the table. We're finding with a lot of our prospects, certainly the larger ones, and millions, tens of millions of dollars on the hospital side that we've been able to find just managing these 7 items on the screen right now. 7 items. So nonetheless, a lot of opportunity here. Optimize coding to mitigate your issues. So I just talked about the lost revenue side, but also the audit risk. If you're overcoding or upcoding, you certainly don't want to get caught there either. So coding is a very big piece. We'll go into with coding on, and certainly with IC10, it's a whole new ballgame. Starting October 1st, coding audits and just coding in general is going to get much more complex. You can't use the standard family of codes anymore starting October 1st. So this is all barreling down on you, and that's why we went to this webinar today and get out in front. But again, there's a lot of opportunity for additional revenue. Protect yourself, but then also go out there and get paid for all that hard work. But we do all this as part of what we do with a practice. Again, any size practice, any size hospital. We reconcile for missing charges in our chart audits. We're looking for services, tests that were performed that weren't billed, screening, like BMI screening, looking for missing modifiers. Again, and we're willing to go at risk and even, make commitments saying we'll bring an extra 5%, 10%, 15% revenue into the practice. So that's something that, we look to make those commitments. Certainly we do some audits on the front end to find out how much, you're really leaving on the table. Very important. And keep the future in mind. This is, again, I come from the electronic health record background and the health IT background. It's really optimized coding and go in there and we'll actually modify the EHR to ensure it's capturing everything that you need to capture if you're going for PQRS or some other alternative payment model or district program or even PQRS, MIPS, whatever it is, whatever quality reporting initiative that you want to participate in, we'll go out there and we'll set your health IT platform and program up. And also, for example, capture the information to capture inside your EHR to make sure that you have the right dashboard, that we're checking those dashboards. And again, this is not about just, we don't sell software. It's all about services. A lot of people have all of the software they need. Certainly if they have a top 10 EHR and then top 10 EHR or top 5 in their specialty, they have all the technology they probably need. It's about the expertise and services and coding and setting that technology up and just doing the audit. And I mentioned here credentialing, monitoring par and non-par care providers. There's so much opportunity, again, to just to stabilize where you are today. I talk to a lot of people, we're fine on billing. And then we do a quick audit, even have a quick conversation and realize they're off by $30,000, $50,000, $100,000 a month. depending upon the size of their practice. There's so much opportunity there that can be fixed. And really optimizing collections with eligibility verifications, prior authorizations, and certainly managing fee schedules. How many people go back and match their fee schedules to what they contracted? Less than 5 to 10% of practices do that. So it's very, very important, and those are all services that are critical to your revenue cycles today. This is not about healthcare tomorrow. This is about what you can do tomorrow or today, this afternoon, to begin bringing a lot of extra revenue to the practice. I talked about efficiencies and economies of scale. So really understanding and managing your cost structure. Again, this is the stuff that the expertise that we bring along in our team. We look to streamline operations, increase the throughput. How can are there access to see more patients, or just aligning the practice so patients have a better flow? Cost of operations have increased over 50% in the last 10 years. You've got to mitigate this, because you just can't keep on. We've got to optimize your revenue cycle. We also look, how can we mitigate and reduce your costs, or at least stabilize the rate at which your costs are growing? Very key to our operation. Understanding your current staffing model. What do you need to do? And we're not, we come in there, we have a lot of co-sourcing and really working with existing teams, but looking at how can we optimize every employee? How can we, increase collections, and how can we shift around resources to do those kind of pieces? That's a lot of the stuff that we love to sit down and help and offer best practices around. You got to reduce the cost per case. You've got to, increase cost per claim, or decrease your cost per claim, increase your revenue per claim. And again, these are all opportunities that exist today, and certainly much more moving forward when you start to engage MIPS and other programs. You've got to leverage innovation internally and externally. But like I said, and you read a lot of practices out there already have the necessary technology, so you don't need to go buy more software. But it's about really leveraging what you have, bringing on the expertise to optimize your revenue cycle, and then engage whatever payment models that you want to engage, whatever, MIPS or, anything else that you want to go for. And I'm going to cover a lot of those programs here very shortly. And also very near and dear to my heart, what we do is we implement clinical, financial, and administrative best practices right across the board. That is so key, and that'll bring so much opportunity, and actually brings a comfort level to our customers and our prospects, because we actually get in there and help you have the, confidence, but then also the knowledge that you are optimized. You are using best practices, whether it's coming from your specialty or your region or even your teams. I mean, we'll actually collaborate on some of the best practices, so you can roll them out together. But we'll bring you all that we have specialty-based. So on the specifically KPIs, very near and dear here, because you've got to look out and know what your key performance indicators are. We set them up, so you want to have them to make sure that your revenue is optimized and your cash flow. We look at them how root causes and your appeal success rate. So we'll set up all these KPIs and work alongside your team. Got to look for underpayment reviews, incomplete missing charges. Again, I mentioned here efficiencies and throughput. We've got to see how long are patients waiting, how are we handling cancellation and no-shows, what can we do to improve that? There's a lot of best practices there. Sorting turnaround time. And then also, like I mentioned here, operational cost and cost per case. We've got to truly understand the cost per claim within the practice, and we can do that. And then we certainly do audits to ensure we start with the right KPIs, and then we manage every month to ensure that we're hitting those KPIs along with the practice. So now moving over to some of the programs, I'm sure a lot of why you're here, MIPS and MACRA. And in the last 2 weeks, some really good information came out on MIPS. So I'm certain if you haven't heard this, they came out, we should have the final rule now by November 1st. And I think everybody may know this, but it's MIPS, or MACRA, stands for Medicare Access and CHIP Reauthorization Act of 2015. So I think hopefully everybody knew what MACRA stood for. But specifically, going out to MACRA, the published rule came out in April. And again, we should have the final rule by November 1st. So that means hopefully in October. I think a lot of us were expecting the final rule to come out in November, maybe even late November, because whenever they say the month, it's usually towards the end of the month. Here they said by October 1st. So I'm hopeful that it'll come out maybe in October. But I'm actually going to walk through a lot of the components of what the NPRM, the Notice of Proposed Rulemaking, what the proposed rule, what it says, and then usually it comes at a smaller scale when the final rule comes out. They kind of throw everything out there in the proposed rule, and when the final rule is published, it's actually a smaller version and it's scaled down. So I think it's all good news. But specifically on I guess the flexibility, I would say, for the 4 options that they came out with about 2 weeks ago. So option 1, and this is good news across the board for everybody. Option 1 allows providers to report any data to avoid a negative payment adjustment. So I think they're here. We'll have to see the specifics, and I'm sure you'll get more money if you report more information, and maybe a little bit less money. But we'll have to see what they actually mean by if you report any data, you can avoid a negative payment adjustment. So you may actually not get negative, but you actually not getting positive if you don't submit maybe for the full data set. So we have to figure out what that means. But I think it's very good. It shows that they're making an initiative to say, all right, we don't want to ding anybody if you're trying, and that's a great first step. So I think option 1 made me very, very happy to see that. Option 2, and I think it's what a lot of us had called for and we expected, a shortened or reduced, they call it, number of days, but a shortened reporting cycle and a performance cycle. So there's probably 90 days. So if you report for 90 days, you can achieve MIPS, your Merit-Based Incentive Payment Service system. You can achieve your goals hopefully in 90 days. I'm hoping that's what we see for option 2. So you don't have to start on January 1st, 2017. But again, the only thing I do want to cover off real quickly before I go on to option 3 is they aren't pushing MIPS off or MACRA implementation off. I think a lot of people thought, well, they'll push it off to 2018 or 2019. They're not pushing it off. It's going into effect in 2017. But now these 4 options for flexibility saying, hey, you either can start, option 3 is you actually can start January 1st. We certainly have a couple of customers that are going to be going down starting January 1st to a full 365-day quality reporting period. But I think a significant majority will actually fall into option 2, where they still want their full incentive, but hopefully they can just report for 90 days and still get their full incentive, get their full 4%. So we're hoping that's what we see. But no matter what, they talk about, you can report for a reduced number of days. It might be 180, it might be 90, we don't know. But I'm very happy that they're talking about not having to report for the full 365. But you can get your full incentive, and they might even have some other bonuses here if you do for the full 365 days as an option 3. That option will be there. And then option 4 hasn't changed much, but that's certainly you can participate in an advanced alternative payment model, which is known as an AAPM, such as Medicare, Shared Savings, ACO, and I believe it's track 2 and above. I don't think track 1 qualifies. But it may. We'll see what the final rule comes out as. So bottom line with this screen is we should see in the next 35, 40 days or so, we should see the final rule for MIPS and MACRA. It's going to be rolled out in 2017, but a lot of flexibility to be successful. So I think it's great news for everybody. I'm not going to spend a whole lot of time on this next slide because this is very common. This slide is basically this information has been available for about 5 months now, 4 months out there. But MIPS really is relevant to everybody that takes Medicare. I'm going to walk through what it means to a lot of specialties, some of the key ones. As we saw from the attendee list, I try to pick a lot of specialties that are going to be on the line today. And I'm going to walk through that here subsequently. But, plus 4% or 4% year 1, 5% year 2, 7% year 3, and 9% year 4. Now, you can say, well, my Medicare population is not too high. I only have 10% or 50%, 15% or 20% Medicare, so it's not that much money. The important thing to understand here with MIPS and with MACRA in general, but MIPS is the reporting system, every commercial payer is moving down this path. So if you say, well, I don't have that much Medicare, or I'm not going to take Medicare in the future, the odds of you taking Medicare at 100% is somewhat slim. So you're going to get a ding, and also there's nowhere to go and not do this quality reporting. All the commercial payers are moving down this path. There are dozens, this is a whole other part of my presentation, there are dozens and dozens and dozens of quality reporting initiatives across this country, dozens in each state, depending on what specialty you're in. So they're coming out. And so what MIPS does, and MACRA in general, it begins, in what Meaningful Use did initially, is it begins to put the framework around your practice for capturing the information, reporting it electronically, and really just implementing that health IT within a practice or within your hospital. And now all the quality and outcomes-based payments are starting to flow. So this is only going to ramp up. So I'm afraid that if you choose, I don't want to take Medicare, or I'm going to not do it, you just know where to go, unless you just do a cash-only business, because all the payers are moving down this path. So I just want to make sure that's clear for everybody. Here are some of the performance. Here are the 4 performance categories. So you've got quality, which replaces PQRS and will account for 50% of your total performance score in year 1. Resource use as category 2, which will replace the value-based modifier and account for 10% of your total score in year 1. Clinical practice improvement activity accounts for 15%. And then your advancing care information replaces Medicare meaningful use and accounts for 25%. So these are the 4 categories. We will certainly learn more about these. And I'm going to cover some of this in a subsequent slide as well. I didn't want to overwhelm you, but I have a lot of information on MIPS here to come. But these are kind of the high level, and you know, as you begin to explore and implement, MIPS with your practice or hospital practice, we'll dive in specifically into each of these 4 categories. But here's an example. So I'm going to walk through some of the big specialties on the line right now. The my team customized these slides just for this presentation. So just to understand what this means. So CMS expects 29,000, almost 30,000 physicians or cardiologists per se to be included in the MIPS, actually qualified based on your Medicare population. About 30,000 cardiologists in general will participate and will be able to participate in the MIPS program. 62% should receive that full 4% payment adjustment, but also up to 38% might receive a negative for not participating or not participating successfully. So it's very important. Again, this is getting the right partner, someone who knows these programs, who knows the team, the services. Again, it's not about buying software or having somebody, because a lot of these practices, they don't have the resources on board to navigate MIPS. Meaningful use if meaningful use was anywhere near an issue, MIPS is going to be a much larger burden on the practice. And that's why, I started to help to found iHealth, and why we do what we do is because practices need service, they need help to achieve these metrics. I mean, it comes to like mind goal at risk with you to be successful here. But for an average, you can look at the additional money. So this is just Medicare money. Average for physician cardiology practice, additional $72,000 that they will receive by participating in MIPS, or $72,000 loss if they weren't participating in MIPS. And that's for an average. That's for an average 4-doctor cardiology practice in America. Now, again, if you have a higher than average Medicare population, this would go up or down. And if you have less, obviously, it'll go down. So this is just on a median average for the, if you have a median for your specialty average of Medicare patients, and every specialty is different. But again, the average practice in the country, 4-doctor cardiology practice, will get an extra $72,000 for participating in MIPS. Yes. So on the cardiology side, here's another deeper example, kind of diving in to cardiology specific. So number of specialty measures included, there are only 15. So it was very important to me for us to call this out for our listenership and for everybody that takes time to spend on our webinars. It's not this massive black hole. There's only 15 measures, and actually 4 measures that you've actually seen before, but they've received changes. They've been part of either meaningful use for the program. So, this all builds off of meaningful use and other programs that you may participate in today, or just core measures as part of your specialty and what Medicare has rolled out in the past. But again, it's only 15 measures. So there's 9 process measures for effective clinical care. There are 3 efficiency measures for cost reduction and 3 outcomes measures for patient safety. And here's just a couple of examples. I don't have all 15 listed here, but these are just some examples of what the measures are as part of cardiology. So, the reason why it was very important for me to at least show this glimpse on the slide is because I wanted people to understand it's not 100 things that you have to do differently. There's just 15. But this perfectly positions you to navigate the future of healthcare very successfully if you're a cardiologist. So just an example. Moving right along, there's a lot of radiology practices on the line as well. So I want to take the time here to show you here about 35,000 physicians will qualify for MIPS, or radiologists will qualify for MIPS. about 50% will get a positive payment adjustment, and about almost 50% will get a negative because for various reasons. So it's very important that you're in that 50% where you get an extra $76,000 for the average 10-doctor radiology practice. So roughly it's $7,000 per radiologist. And this is just for MIPS. Never mind. I'm going to go through some other examples. I think on internal medicine for when I layer in meaningful use, and I layer in PQRS, layer in MIPS, the money gets pretty big. And again, this is just for your Medicare population. Never mind what the commercial payers are also starting to roll out. But the great thing about participating with MIPS is it does position you for that quality reporting. It gets you captured information so you can report it to anywhere else you want to report it. You'll get additional dollars. But again, $76,000 for the average radiology practice with an standard average rate population of Medicare patients. So here's an example of, on the radiology side, if you actually, this is cumulative. So looking at opportunities for money or payment hit. So if you weren't, if you were to actually participate in on the Medicare side with meaningful use, PQRS and diabetes modifier, then you'd be doing well. If you weren't, you're probably losing up to $120,000. So there's a lot of money. And as you see, it's almost $40,000 in 2017. So a lot of money is being left on the table if you're not navigating meaningful use successfully, PQRS and the diabetes modifier. And then you can start to look out and then MIPS payment adjustment as you go forward. So again, something to keep in mind, this is the standard radiology practice across the country. And again, I know I'm going fast through a lot of these different, we'll share all these slides with you, but I kind of want to give a lot of glimpses into different specialties so you can kind of understand how it affects you. Internal medicine, there's about 90,000 physicians that will qualify for the MIPS program, and they anticipate 60% being successful and 40% not, just because of everybody's different demeanors on participating in these programs. We want every single one of our customers to get access to their money. So on the 7-physician internal medicine practice, an extra $53,000 just for MIPS, never mind other programs that they'll participate in. And this is just in your Medicare population. And if you have a higher than average Medicare population, it'll be a greater incentive or it'll be a greater adjustment. So, and again, we dive into all of this with each of our prospects and each of our customers for sure. Internal medicine. So if you're looking at internal medicine and again an average practice, I think the example was 7 physicians. So here you're talking about a little over $78,000 of additional money available to you under meaningful use, under PQRS, and the value-based modifier, and only grows in 2017 and 2018. So a lot of, obviously if you are participating, then you'll have extra revenue. If you're not participating, it is pretty significant revenue hit that you can begin to expect. And a lot of people, when we visit practices, people don't realize the meaningful use 2% they left on the table. That's the PQRS 2% they left on the table. The CCM money left on the table. The patient medical home money left on the table. And never mind MIPS. I mean, there's a lot of hits coming financially. So again, you want to optimize your revenue cycle and then begin to participate in all of these programs successfully. Here's an example for an average 6-doctor family practice group, basically an extra $30,000 a year or a $30,000 hit. And again, this is just for your Medicare population. And again, the commercial payers are all moving down this path, but they expect 60% of family docs to achieve the incentive and about 40% to miss the incentive for one reason or another. Again, that's why partnering with the right company and the right people is very, very important. On the orthopedic side, a larger specialty for sure, your standard about 21,000 orthopedics across the country will qualify. They expect about 53% to receive a positive payment adjustment and about 47%, 46% to receive a negative. So for an average, so what this means for an average 9-doc ortho group, about an extra $100,000. And again, this is just the Medicare population, an extra $100,000 in revenue or a financial hit of $100,000. And again, this all starts in a little over 3 months with 2017. On the OBGYN side, this is something that we looked at cumulatively. So looking at all of meaningful use, PQRS, and the value-based modifier. So again, almost $10,000 in 2016 of revenue. This is per OBGYN. 2017, it goes up to well over $10,000. And then as you see, it goes up about $5,000 meaningful for MIPS and so forth, that's positive or negative. And that's per OB. So we want to kind of show what this means per doctor, but per OB. So if you have a 10-doctor OB group, you're looking at 60 plus 70,000, $60,000 plus dollars just on the MIPS program of either a financial hit or financial opportunity. And again, that's just with Medicare. Never mind all the other programs that you'll participate in. They're coming out. So that's really MIPS, and I think this is one of the very first, or this is the first presentation that we're aware of out in the industry that people are actually going down there and showing you the financial aspect. But again, these are the bare minimums. And actually, I didn't want to make the numbers too big and overblow it, but these are the bare minimums when I've gone through the numbers. Some practices, they have a higher than average Medicare population. Those numbers could be 25, 30% higher, and you're up to $100,000 or $150,000 of revenue hit for an average size practice. And if you have a higher Medicare population and more care providers than the average practice, then your numbers could be much higher financially. So again, want to make sure everybody kind of sees the hit. Now on the screen are just a couple of state-based incentive programs. So it does matter what Medicare does and what the federal government does. But again, all of these private payers, commercial payers, all have programs rolling out, either state-based or commercial payer-based. There's additional revenue. So there's a PCMH program in New York. Some of our customers, additional $300,000 in incentive payments available under PCMH, a significant opportunity that people PCMH practices are achieving. Here in Georgia, there's increased revenue for primary care visits under the Georgia PCMH University, and certainly there's a whole quality reporting initiative that we're actually about to, or incentive that we're actually about to roll out here just in Georgia. But we're doing this across many states. But just again, a lot of opportunity on the oncology side. As an example, in Georgia, $160 per beneficiary for OCM services. So again, and these are just examples. We do this for most of the major specialties out there. In Kentucky, there's the Enhanced Personal Care Program. So again, fee increases across the board. Also, there's the CPCI, the Comprehensive Primary Care Initiative, that's available in Kentucky. They modeled that after a lot of the national program, the government program. And then certainly Florida has a Blue Cross Blue Shield value-based care initiative, which is actually adding up to 16% on a contract with fee schedule. So again, these are available in almost all 50 states with almost all payers of these different opportunities. It's just getting the right partner in there to help you navigate it. So as we begin to wind up our time and open up for Q&A, what will it take to succeed financially? Again, I covered a lot of this, but providers can't afford to relinquish any of the money they've earned. You've worked so hard, and just, everybody shows up and goes at it every single day. And again, when we go in there and do chart audits and look at the revenue cycle, there's tens of thousands of dollars left on the table. And that's the stuff that we want to go get. We want to find ways. Like I said, we'll make actually the financial commitment to go help and partner and optimize your practice in that way, and really optimize efficiency across the board so you can achieve clinical health as well as financial health. And I'll talk about the clinical side next. But you got to pay close attention to nuts and bolts. Again, certainly, and I'll cover these in order here. Well, eligibility verification for sure, authorization management, but optimized coding. Coding changes every single year. Unless you have a coding expert that educates and goes through coding every single year for your specialty, for your main primary procedures, you're probably leaving, again, tens of thousands of dollars on the table. And that's the stuff that we love to go in there and we love to find. And then we'll even go in there and, again, modify your EHR to capture a lot of this information and optimize your practice. And really leverage the technology that you've all invested in. That's a very, very big piece here, is leveraging all of the money that you've already invested and all your hard work. Claim creation, scrubbing, and submission, denial, looking at denial and really get to the root cause, not just resubmitting, but getting at the root cause to reduce your denial rate over a period of time. And then close analysis of the payer contracts and variance rates, and then putting KPIs in place. Knowing where we're starting And then again, because we go at risk with our customers, so it's very important for us to bring you additional revenue, because when you make more money, we make more money. So it's a very key piece. And all your partnerships should be set up like that. I believe. And everybody, I know 25% of the people on this line have heard me talk for the last 10 years. You know that, I believe in holding vendors accountable. Everybody that sells you anything, everybody that's a partners with you should be held accountable. As you make more money, they make more money. You make less money, they should make less money. And that's the mantra that I brought to iHealth. What will it take to succeed clinically? Obviously, population health and care coordination. It's the heart of all these new payment models. That's a lot of the stuff that we love to set up, the dashboard, and help. And not all that's different, depending upon your specialty, depending upon how you want to practice medicine, what programs you participate in, different levels of population health, different levels of care coordination, certainly. But what we do is we integrate clinical, financial, and even administrative information to optimize your practice, to look at, customize, and create customized dashboards within your EHR and KPI dashboards, so everybody can understand what you're trying to achieve, what you're succeeding at, what you're not succeeding at. Kind of red light, yellow light, green light. So we make sure that we're all capturing key measures, reporting on those key measures, and I call it data visualization, but really visualizing what you're trying to achieve and then what you are achieving. We'll set up monthly scorecards to review clinical and financial key performance metrics. So collections, denials, but also how you participating in this, how are you succeeding, what measures are you missing on right now, how can we fix it so we don't have a financial hit at the end of the year. All these kind of dashboards and KPIs are set up. Address those, and certainly key to most specialties is addressing those most in need and who are the greatest financial burdens, because you're going at risk now a lot more. A lot of your risk-based contracts, so we'll actually help you find those patients that might be costing you a lot or have a lot of opportunity for clinical improvement, for improvement across the board in their outcomes, and that way you make more money. We actually have to identify those patients, because that's where you actually be making a lot of money, a lot of opportunity for low-hanging fruit there. And then just, of course, coordination across the care continuum to optimize outcomes. A very near and dear in a PCMH model, but in most models going forward, certainly with MIPS and other programs. And then certainly opportunities for patient engagement, education, and empowerment. That's something that's near and dear to my heart for a long time as well. It's not all about what you in the practice, or you the hospital, or you the care provider, or you the practice administrator, or you the nurse need to do. It's about what the patient needs to do as well. So we help you certainly with those aspects. And I mentioned this at the start of the presentation here. I personally believe that all care providers that intentionally and deliberately engage new payment and care delivery models and create the right partnerships will have more opportunity in the future than they have today. And again, that's the whole reason why we started this company, and why it's been a lot of fun through the years, because we get in there with our partners, and partners being our practice in our hospitals, and just allow them to thrive. So with that, Alex, if you want to come back on, and I'm sure we have a full boat of questions. I covered a lot of hot topics and topics that create a lot of passion inside of people. So I certainly want to be able to address these. So let's go ahead and pull them up here.
Thank you, Justin. We're now going to begin answering the questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Justin, our first question asks, is there resources available where I can see the MIPS payment amount or penalty for my specialty and number of physicians?
Great question, and me and my team, we created this, so including Alex, who's on the team right now, the public policy manager, Sherry Westlake on my team, and others. So we actually created a lot of this. I don't know if there's anything out there on the industry by specialty, but if you want to email us, I think it's advisor. The email address is advisor@ihealthinnovations.com. You can send it to Justin. My email address on the screen right now, but I think just very easily advisor@ihealthinnovations.com. Any questions that you have, we would be more than willing to try to help you and partner with you. So next question.
We are a multi-specialty group. There are little value-based program options that make sense for our scope. How do you see value-based programs moving forward? Do you expect CMS to refine and consolidate, or will there be more to choose from?
Well, I mean, to be honest, there is a lot of opportunity under MIPS, so I do I see a lot more flexibility coming from CMS. Obviously, Medicare doesn't serve anybody if doctors leave them, so I do see more flexibility. I see more program advancement. I see more opportunities for practices and hospitals to engage, and I see more opportunities for revenue coming, but you got to kind of meet them in the middle. I think that's really what we're going to see in the final rule, is that CMS is bending a lot, going to offer a lot of flexibility in the need for care providers to engage. But again, it's not just what CMS does. It's all commercial payers are moving down this path and putting out big carrots, but they're going to have the sticks are coming right behind. They're putting out carrots right now, but the sticks are coming. So it's not, it's kind of a stick and carrot approach. So I hope that helps a little bit with that question, Alex.
All right, so next question. When should I start preparing for MACRA? Is there anything we need to start doing today?
I mean, you're doing it. So you're on this webinar. You're starting to learn. MIPS really does affect. I think the cutoff is 100 Medicare patients and below. You don't have to participate, but anything you get more than 100 Medicare patients, there's opportunity to make money. And so, and certainly, if your Medicare volume's above 10%, then there's a lot of opportunity and a lot of money and again, it perfectly, a lot of money to go get, but then also it perfectly positions your practice, because this, again, where it's starting. That's just year one. Year two, the incentives go up, or the penalties go, get worse. Year three goes up, and so that scale is only going to continue. So it's very important to engage. You're doing it now. You reach out to companies like mine who can help you optimize your revenue cycle and can help you make sure you're positioned properly for MIPS or whatever quality reporting initiative that you want to embark upon. That's the kind of the fun part. I love coming across them. I know it's a passion of yours, Alex, that we get out there and we really help these practices and hospitals navigate these new payment models. So I think they're doing it, but yeah, the time is to start is now. I mean, there's lots of things that we get done today to shore up your revenue cycle, make sure that you have the financial component cemented, and then begin the clinical component, and then they all drive your long-term financial health and success of your practice and hospital. But they're starting today by being here and reaching out to companies like mine, and also your company needs to make sure they're going at risk. We call it the WRAP program and the WRAP service, but it's the Wellness and Revenue Assistance Program called WRAP, and that's really what we do. That's the at-risk program that we'll go at risk for the practice or a hospital and help them through these payment models. So, good question. What's the next one?
Perfect. Next question. What role do you anticipate consumers will play in how we practice?
Oh, that's a great question, and I kind of touched on that in the beginning. Consumers have more choice than ever before. They're actually going at risk faster than anybody else in healthcare because, we're all patients. We all watch our healthcare. I think the number is 98% of American healthcare costs have risen in the past year. So everybody's healthcare costs are going up. And our high deductible plans are being implemented. We're paying more out of pocket every single year. So consumers are making more choices on where they visit. And again, this is where it gets fun for me too, because I have a lot of passion around, marketing and helping practices grow and garner more patients and garner more right patients that they actually want, as part of their base. So, that's the patients are going to get more. They're more educated than ever before. They're going to continue to get more educated. They're making more choices. They are doctor shopping, and I see patient shift. You also, this way, you talk about years ago, and it's so true today. Is these payment models are rolling out, these little mini ACO models or clinically integrated networks that are popping up around the country, and doctors and care providers, practices that aren't in hospital even, that aren't strategically navigating payment models, are probably losing patients. They don't realize it's very important, because they're losing them to these new ACOs. They're losing them to these CINs, clinical integration networks. And you've got to look at, what are your patient visit volumes? Are they increasing? Are they decreasing? And either way, you've got to know how to best manage those to optimize your revenue and your opportunity. But patients are making informed decisions. They are doctor shopping. They're switching practices. But there's so many opportunities to get them in there for annual visits, for checkups, and a lot of opportunities for additional revenue there as well. But you've got to manage it. It's got to be a proactive strategy. And again, it's what good partners like us we bring to you. So, great question.
Great, thanks.
Well, actually, let me one more piece there. Depending upon the payment model that you're in, anywhere, but over the next 3 to 4 years, 5 to 15% of your practice revenue predicated on patient satisfaction in one form or another. 5 to 15%. If you're in an ACO, it's 10% today. So I know a lot of people aren't in ACO. Only 10% of doctors are in ACOs today. But so 5 to 15% are predicated on. And there's a missed bonus on patient satisfaction. So I'm glad we actually touched on that, because 5 to 15% of your payments are based on patient satisfaction, and it could be as simple and even non-technical and non-NIPS related, not ACO related, as patients coming back. Patients wanting to visit you. Make it easy, again, like I mentioned at the beginning of the presentation, make it easy to schedule. Make it easy to contact your practice. Make it easy to schedule your practice. Make it easy to pay your bills. Those are all very simple things that practices and hospitals can do today that are they'll make you so much money, but people don't realize it. And it's just another project to make it easy to do business with you. That's what everybody in the global economy is trying to do, with apps and online shopping. Make it easy to do business. Practice in hospitals, you just think the same exact way. And you don't have to spend a lot of money to get additional revenue in those areas. So hopefully that all makes sense. Great question.
Perfect, thanks. Next question, how do I find out which incentive programs are available in my area?
There's a lot of great sources. I mean, Medicare has a great website that's very easily, it's pretty consumer centric. So you go to websites like Medicare, they have their CMMI, that's the Innovation Institute, the Centers for Medicaid and Medicare Innovation Institute. The CMI page is very helpful. It shows you geographically what programs, not only the federal government programs, but also a lot of the state-based programs. But and then talking certainly to your plans, but you can reach out to Humana, Aetna, and Blue Cross Blue Shield, and all the different plans that are your community that you work with. But also ask them what they offer for risk-based contracts. Ask them what they offer for PCMH incentives or for your specialties. Be proactive and ask them. But also you can always come to a company like us, like iHealth. We help customers do this, exactly what we do for our prospects and our customers. So we go do all that research for them. Great question.
Great. So we are participating in a patient-centered medical home. Will that count towards the MACRA alternative payment model track?
It will not. Unfortunately, and we could see something different in the final rule because there was a lot of kind of an uproar on this one. But on the PCMH front, it will not qualify you at this juncture for the APM, but it will qualify if we get 100% of the clinical improvement measure. Is that correct, Alex? I think is the clinical improvement measure?
Clinical practice improvement activities. Yep.
Yeah, CLIA. So, So it qualifies you for 100% of that measure. So that's great. But again, we need to look at the final rule to see if that justification for the AAPM track. But right now, the answer is unfortunately no. But you will qualify under MIPS. So, great question. Are there any other ones?
We're going to shift. There are a couple more here. We're going to shift gears a little bit. Optimizing our revenue cycle would be great. You covered several good points, but where would you suggest we start?
Well, I mean, this is the kind of the tougher part. The tougher part for a practice to do it on their own, but you got to look at coding. You really need to understand what are the, and to look at whatever new codes are available for your specialty. Look at looking out over your patient base and your visit volumes and what you have your standard 6 or 8 services, but understanding how, what's available to you on the coding side, then also on the changes coming with ICD-10. That's a big piece that we will, that's something that we do on our side, but that's some of on the revenue cycle side, that's very, very important, and a lot of money. That's where we capture a lot of money just on the coding side and doing a coding audit. And then making sure that we're actually accurately coding for our top 10 visits or our top 5 visits or services. The other side, reducing denials. So there's many ways to send a clean claim or authorizations and to capture those components. So I think reducing denials in those areas, get their technology innovation into there and some best practices is very helpful. Credentialing is massive, a lot of money. I mean, there's one of our hospital customers, 150% increase in revenue once they had us take over and co-source their billing and take over some of the billing with them and to help them on collection. It was an extra $9 million a year, every single year, just by playing the game that the payers put them through. We had to do the credentialing every single month, re-credential every single month. I brought an extra $9 million. So that's the kind of stuff. That's a lot of fun, and it's a great partner or a great customer of ours, and it's mutual admiration there because it's brought them so much additional revenue. So that kind of stuff. Those are some of the big high points that I would touch on, or what they can start today.
Perfect. And can you expand a little bit more? We have one more question that says, what's the most common issue with revenue cycle? For example, should we be paying closer attention to coding, missing charges, fee schedule, etc.?
And the answer is yes, across the board on all of those. Those are all key components in some of the areas. And that's why, like I said, I don't mind making some guarantees that we can bring an extra 5% of revenue or 10% of revenue, is because all those areas that you just listed are big opportunities for additional revenue. And it's just a great opportunity for a lot of mutual success. So, the answer, again, across the board, yes. There's no one, it's all of them.
Great, thank you. We're approaching the top of the hour, so we'll go ahead and conclude today's webinar. Thank you, Justin, and a special thank you to everyone for taking the time to attend today's webinar, Best Practices to Successfully Navigate the Future of Healthcare. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. As a reminder, Justin's slides will be shared in a follow-up email within 24 to 48 hours, and we will also include a link to view a recording of today's webinar in case you want to review again or share with any peers. On behalf of iHealth Innovations and our presenters, thank you for joining us today and have a great rest of your day.
Thanks, everyone.